Welcome, ladies and gentlemen. Thank you for joining me. I'm Dr. Silva. Welcome to my channel. For those of you who are not familiar, I am a board-certified psychiatrist with almost 30 years experience diagnosing and treating mental illness, and I've helped thousands of people better navigate psychotropic medication trials. So please check out my private online academy, notonanemptymind.thinkific.com, for my best premium content. Also, please, if you learned something today, please take 2 seconds to hit that like button so that other people will also be more likely to find this video. I'm still a bit of a needle in a haystack, so please do a good deed and spread the word if you like what you hear. Today, I'm going to talk to you about brain fog. I'm talking about cognitive dulling, and specifically as a side effect of medication. Cognitive impairment as a side effect, and how you might not even know you're experiencing it, and the ramifications thereof. How to spot it, what to do about it, and why it's important. And I have a personal account of this. This very thing, astonishingly, it only occurred to me well after I started researching and writing this presentation. I was working on this video, which just goes to prove how even when the symptom is glaring, and believe me, I noticed it and complained about it to family members, a person often doesn't put 2 and 2 together and realize that it's a medicine they're taking that's causing it. And I'm a board-certified psychiatrist, which also goes to show we all have a blind spot for ourselves, no matter who we are. That's why I have a psychiatrist and a psychotherapist, and in an ideal world, so would everybody. More on my own experience in a moment, but I also want to talk about cognitive deficits in the context of major depression, another super common context in which we find these mood-dependent symptoms, and for you providers in training out there, another context in which we often miss those signs. That's what this video is about, the fact that sometimes cognitive deficits are not obvious, neither to the examiner nor the patient, especially when they're subtle, gradual, chronic, or all of the above, and how these insidious but reversible forms of cognitive decline can be detected and remedied. I'm talking about reversible dementia. In the context of major depression, dementia is a proper term. For example, what used to be called dementia of depression. That is, dementia due to major depressive disorder, sometimes called pseudodementia. But just because it's reversible and due to depression doesn't make it pseudo, in my opinion. Pseudo means false. It's not Alzheimer's or Parkinson's, that's what that's supposed to indicate, but it is dementia. There's nothing false about it. Dementia, from the Latin demens, out of one's mind, literally without mind. Another term that's used is depression-related cognitive impairment, DRCI. What we call it doesn't matter. I always say that. In psychiatry, we're diagnosing syndromes half the time, and it doesn't matter what name we put to it. It's a spectrum of severity, from cognitive dulling to more serious cognitive deficits to frank dementia. Whatever we call it, it's cognitive impairment, whether it's reversible or not reversible. Diminished cognition due to various causes. And in this presentation, I'm going to be focusing on medication and depression. Because it's reversible, it's important to detect it and do what we can to treat the underlying cause when the cause is as specific and obvious as medicine or a major mood disturbance. When cognitive dulling is due to a mood disturbance, we treat the depression. Hopefully we're doing that anyway, right? But importantly, knowing this will inform our selection of antidepressants. When cognitive decline is a side effect, we can withhold or attenuate the offending agent. If we realize that a medicine is causing it, we update the risk-benefit analysis and maybe do an about-face to salvage the ability to think clearly, to focus and organize one's thoughts, to plan and choose and decide, to exercise good judgment. All of these fall under the rubric of intact cognition. And when there are deficits, you may not be more distractible or noticeably forgetful and still be fuzzy enough to have it affect you. Some patients don't know they have cognitive decline because they have cognitive decline. Some patients are so depressed, they don't notice. They're not noticing much of anything. They're sleeping all the time. Patients who are severely depressed with psychomotor retardation and significant cognitive decline are unlikely to complain of cognitive deficits they don't even know they have. They're not thinking along those lines. Now, one argument is, if it's so subtle and unnoticeable, what's the problem? The problem is that it could still be negatively affecting you, even if you don't know about it. That's true of a lot of mental health symptoms. What you don't know can get you, especially in psychiatry. With major depression, we're going to treat the mood disturbance anyway, and since the cognitive deficits are a direct consequence of the depression, the pathophysiologic process by which cognition is impaired is wrapped up in the major mood disturbance. Those patients will improve whether or not we detect and elucidate the cognitive symptoms. But knowing about them not only helps us select the best medication, it also gives us a set of objective findings with which to measure improvement. So the knowledge can be leveraged, and it makes us better clinicians. It's not just academic. If it's there, we want to know about it so that we can monitor it, so that we can select our medications appropriately. It's not superfluous knowledge, although it's missed all the time. With cognitive dulling that's secondary to medication, however, there's a greater pitfall in that it might go entirely unnoticed and untreated if the patient isn't complaining about it, which is common, or if the practitioner fails to detect it independent of the patient's complaints. With medication, we especially need to know it's there and gauge its pervasiveness and severity so that we can make an accurate risk-benefit assessment. It's more common than we think. More on all of that in a bit, but first, some definitions. The term cognition refers to the mental processes that occur in the brain, which include thinking, paying attention, using language, both comprehension and production, learning, i.e. acquiring new information, memory, storing and retrieving information, and executive functioning, which includes planning, multitasking, exercising good judgment, and impulse control. Cognition also comprises perception, which is an integrative function, integrating and interpreting sense perceptions, visual and auditory cues, tactile and olfactory stimuli, touch and smell, and other input, including pain. Cognition can perhaps best be summarized as comprising what we know, or what we think we know, which is tantamount to what we believe, what we tell ourselves, and what we lead ourselves to believe based on all of these inputs filtered through our personal biases, attitudes, expectations, and prior experiences. It's a powerful tool, our cognition, one that can be harnessed for damage control. In my opinion, the most effective psychotherapeutic intervention is cognitive behavioral therapy, which aims to change the way we feel and consequently behave by first examining and challenging our belief system. Cognitive deficits are those that detract from the speed and/or accuracy of those cerebral functions. Not just accuracy, but processing speed, just like a computer. When cognition is severely impaired, we have dementia, the loss of that global capacity to recognize, categorize, and organize information, to store and retrieve it efficiently and accurately, and to calculate, to plan and judge, and to refrain from acting out. The loss of the propensity or capacity to do this is the definition of clinically relevant impulsivity. And all of this is on the dementia spectrum. It's all related to cognition. When doctors refer to demented patients, we're talking Alzheimer's, Parkinson's, and other Lewy body dementias, vascular dementias, a la Binswanger's, Wernicke-Korsakoff syndrome, which is the dementia we sometimes see in chronic severe alcohol use disorder, and others. Although the DSM-5 retired the clinical term dementia, we now call it major neurocognitive disorder, and there's a mild neurocognitive disorder as well. Doctors all over the world still say dementia. Not all dementias are permanent, however. Most are, at least most of the ones that are formally diagnosed. And here again, the point of this presentation is that we probably miss a lot of those that can be reversed. The ones we really don't want to miss because we can reverse them. Some dementias are reversible if the underlying cause is corrected in time, such as those due to vitamin deficiencies, especially thiamine, vitamin B1, and B12, and E. Thiamine is the vitamin implicated in the dementia due to chronic alcoholism, Korsakoff's syndrome, also called Korsakoff's psychosis, although that's actually a misnomer. It doesn't involve psychosis per se, but you do see prominent confabulation. As well as reversible dementia due to hypothyroidism, a condition known as normal pressure hydrocephalus, subdural hematomas, bleeding and swelling on the brain due to falls and blunt trauma, brain tumors, and cysts, likewise exerting a mass effect. All of these are reversible causes of dementia. Other causes of reversible dementia include meningitis, vasculitis, certain infections, including HIV and tertiary syphilis, neurosyphilis. All, like dementia of depression, can cause a reversible condition that can be treated and cognition restored. Cognitive impairment due to medication, both prescription and over-the-counter preparations, can also sometimes lead to a form of reversible dementia, what we could call dementia in certain cases, in a patient who's not actually delirious and who does not demonstrate other signs of acute intoxication per se, They're not slurring their speech, they're not falling out, they don't have ataxia, ptosis, and dysarthria, other signs of intoxication. So we can't really diagnose them with acute intoxication due to the medication, and we're not going to diagnose a delirium because they don't have a clouded and or fluctuating sensorium, so they just don't meet criteria for those, and yet they have these significant, severe, in some cases, but reversible cognitive deficits. That's dementia. You would just diagnose dementia. And especially in the elderly, who may already suffer from some degree of age-related cognitive decline, and in other vulnerable populations with diminished cognitive capacity. I used to smoke marijuana, and like many people, every time I got high, I would become demented. I would develop major neurocognitive disorder due to cannabis intoxication. That's the official diagnosis there. Characterized in me with severe, and I'm talking severe, but reversible short-term memory impairment, such that if I was high enough, mid-speech, and I'm not exaggerating, mid-speech, I would actually thought block. I would forget what I was saying while uttering it, literally mid-sentence, and I'd have to ask the person I was talking to, who was also usually high as a kite, what we were in the process of talking about. And we'd both have to really think about it to get back on track, and occasionally, neither I nor my conversation partner could recover the thread of our discussion. It was lost completely, forever. I mean, that is dementia, folks. Imagine having that cognitive problem permanently. As annoying as it wasn't always that severe. It was on a dose-dependent spectrum, and it was completely reversible, so the net result was that it didn't dissuade me from continuing to smoke weed. My father, on the other hand, wasn't as fortunate. He suffered from subcortical vascular dementia in his 80s, and he exhibited this exact form of thought blocking, except it was permanent. A tendency to drop his train of thought before it even left the station. Short-term memory impairment that was so reliable and so complete in his final years, it made conversation impossible. He would literally forget everything he started to say, every time, completely, and before he even got started. He would begin to answer you, maybe get a word or two out, and just as quickly his thoughts would slip through the grasp of his mind like water through a sieve. Because in order to finish a sentence, a single thought, mind you, not even a series of thoughts, you need some working short-term memory. We take for granted the super fast, immediate short-term memory, also called active memory or working memory, that we need to finish our thoughts. We don't even realize we're remembering anything. It's virtually contemporaneous with the thought itself until we thought block. It's on the way out already, and it gets stuck. Actually, not so much jams as disappears entirely, evaporates into the ether, because the brain short circuits. My thought blocking on marijuana was never as relentless as that of my father, but when it happened, it was the exact same phenomenon, a short circuit in the hippocampus. It was the same phenomenon clinically, but with disparate etiologies and pathophysiologies, due in my case to THC attaching and overstimulating endocannabinoid receptors designed to respond to endogenous cannabinoid neurotransmitters, molecules like anandamide, endocannabinoids. The THC in cannabis disrupts normal brain circuitry, leading to what clinically amounts to a dementia. Thankfully reversible. I can't tell you how many times I experienced this. I was a pothead for years. The irony is that THC usually makes one garrulous. There's a propensity toward an increased loquacity, logorrhea, literally word flow, also called diarrhea of the mouth. But when the level of THC is very high, this is coupled with a tendency to forget what one is saying. So one is very talkative, but one continually forgets what one is trying to communicate. THC is now being used medicinally, so this is a good example of a medication that disrupts cognition. A little or a lot. It's dose dependent, and different people have different vulnerabilities to this side effect. And then if you pair it in conjunction with other factors like advanced age or other medications that are on board, for example, anticholinergic medications, then you get a synergy that could make it more clinically relevant in one person compared to another. Benzodiazepines, when taken in sufficient quantities, can likewise disrupt the brain's record button, leading to anterograde amnesia, which involves a complete and continuous loss of short-term memory for discrete periods of time. blackouts. Anorograde because what one forgets are events which follow ingestion. What happens after the person took the medicine or got drunk in the case of alcohol, as opposed to retrograde amnesia that would include events preceding the insult or injury. We sometimes see that with head trauma. The patient doesn't remember the accident or what led up to it. That's retrograde. It's not surprising that substances and chemicals can slow or completely block other neural processes that likewise depend upon the flow of chemicals and electricity for the brain to work properly. These are extreme examples, perhaps, that a lot of people have maybe heard about, but most cases due to medication are not severe enough to properly be considered dementia per se, reversible or otherwise, and therefore go unnoticed. More subtle cognitive dulling, which refers to a subjective and/or objective decline in mental sharpness, not a complete loss, associated with slowed processing, reduced attention, and impaired memory, among other possible deficiencies. Note again, the speed of processing can be an important piece. And also note the and/or. Subjectivity is not a requirement. The subject is not always aware of it, and so it's not always a part of the chief complaint. But neither is objectivity. The latter means that clinicians might not always be able to reliably screen for it or ascertain it on mental status examination. We might miss it because these deficiencies can be subtle, but even when we're looking for them, because they also wax and wane. And so we might miss it on any given mental status examination. So if the patient or the family notices it enough to complain, take their word for it, you clinicians out there, even if you can't demonstrate it upon examination. You might not be able to reproduce it on command. It's just like anything else in psychiatry. A person might complain of crying jags and not shed a tear in front of you. You might not be able to elicit that tearfulness, but if the patient is a reliable historian, and if they don't have some other reason to be consciously misleading you, you take that at face value. Mental health appointments are snapshots, slivers of time, compared to all of the rest of the patient's days. But the fact that the former, subjectivity, is also not required means that the patient themselves often may not be complaining or even aware of the problem. And it is a problem. I would argue that it is a problem. This is frequently the case with actual dementia, of course. The cognitive decline itself is so severe, it masks the cognitive decline. You don't know what you don't know. You can't remember that you can't remember. That's confabulation. When, for example, we ask a patient with advanced Alzheimer's what they had for breakfast, and they start telling us, and they're making it up, and they don't know it. But other younger demographics can also experience subtle cognitive dulling and not realize it either. Reversible conditions with features that are usually characterized as dementia-like symptoms, the true incidence of which is hard to accurately determine because it's almost certainly underreported. Under-endorsement of cognitive side effects is likely to be quite prevalent among much younger cohorts, older and younger alike, when we're talking about medication side effects that go unreported. Even when patients do notice their deficits, they often misattribute their symptoms to something else because they aren't expecting a medicine to cause it. Just like me, just like in my case. And so they rationalize. I haven't been sleeping well, I'm tired, I'm under a lot of stress, I'm having a senior moment, when the real culprit is literally right under their nose. They're swallowing it every day. And the doctor never said anything about cognitive dulling. Many doctors don't think to warn about it or screen for it later. It can be missed. There are a lot of medications that are prescribed by a lot of doctors, and the doctors themselves, they don't even know that cognitive dulling is a potential side effect. It's not even on their radar because no one ever complains about it, and unless you're a specialist and you're prescribing that medication all the time, you don't even know. So you don't think to warn about it, and you certainly don't think to screen for it later. I was writing and researching this presentation about how you can miss it due to medication and failed to realize that a medication that I take, Lyrica, pregabalin, was causing significant cognitive deficits. I have been taking it for quite a long time, several years, for neuropathy, and I take a very high dose. It's a big dose, and at first I was very sedated by it, and I developed tolerance to that. But then I also was complaining of clumsiness, that I lacked coordination. I was ataxic. I was always dropping things and fumbling things. It was noticeable, this symptom that I didn't have when I was younger. And I know it's my brain. Why am I dropping things all the time? Knocking things over, misjudging distances. And it was like my proprioception was off. Like I didn't know where the end of my hand was. And also my grip on things seemed like I was just like acting automatically and they were slipping through my grasp. I did not realize that I had yet another side effect that was a dysarthria. So I had difficulty producing words clearly, This consisted of stammering and stuttering and having a really hard time pronouncing words. But here's the rub. It never happened in English. It never happened when I was speaking English. However, my Spanish, though I'm a native Spanish speaker and I'm fluent, my vocabulary is not as good and I'm not as rehearsed in Spanish. I spend far less time speaking Spanish. I almost never think in Spanish. And right now I'm learning to read better in Spanish. It was actually pronouncing the phonemes. My Broca's area, that area of my brain that's responsible for controlling my palate and my tongue and causing actual sounds to come out, there are just certain combinations of phonemes that I don't have trouble with individually, but that's just a word with a lot of syllables, and I'm not used to pronouncing that specific word, and I'm not used to putting all those syllables together in rapid succession. And because of the Lyrica, because it's causing a cognitive dulling, my threshold for having a difficulty pronouncing certain words that I have pronounced maybe a few dozen times my whole lifetime, now I'm starting to see repetition of syllables. I'm crashing where the syllables are sort of knocking against each other, and I don't get the word out and I have to repeat it, and then I still have trouble with it, and then I have to slow down. What is wrong with my tongue? Then I was asking myself this question, and it has to be this medicine because it's very noticeable. Have I had a stroke? A side effect of the medication, but that only affects my Spanish, because only in speaking Spanish is my brain vulnerable to making those mistakes. Here's a perfect example of even after other side effects that were due to this medication were elucidated, and I was like, oh yeah, you big dummy, yeah, of course it's that. That's why my balance is not so good sometimes, etc., etc. When you have this tip of the tongue phenomenon, when you can't think of the right word to say, this happens to me also in Spanish. Sometimes I know the word, it's on the tip of my tongue. That happens a lot more in Spanish because of my command of the language is not as good and my vocabulary is building. So that happens anyway, but it happens a whole lot more when I take a medication that in any way opposes dopamine. And conversely, when I take a medication that enhances dopamine, then I have a facility of language. Not only am I speaking more and maybe a little bit more rapidly, but I have less of that, well, what's the word? What's the word? And so these are very subtle gauges that usually people miss them. And they're not always properly considered side effects, but it's a spectrum and it goes up and down according to your brain chemistry. What's even more insidious, though, is not even realizing it. Not realizing that you're not as smart as you normally are, because that's what it amounts to. It subtracts IQ points. It disables your intellect, and depending on your reserves and how well educated you are and how much you're using your mind and exercising those faculties every day, you'll experience varying degrees of difficulty. Now again, one could argue that if it's not noticeable and the patient isn't complaining of misplacing things all the time or forgetting things, missing appointments and such, that it's not clinically relevant. What does it matter if it's not bothering anyone? But it does matter. I would argue that when a person underperforms on an exam and doesn't know, or doesn't get the promotion at work, or has a car accident and chalks it up to bad luck or just random mishaps, not knowing that they have cognitive impairment because of high-dose Benadryl they've been taking to get to sleep, a medication they can get without a prescription, harm is being done in that example, and countless others. A patient doesn't have to complain about a symptom or even know about it to be harmed by it. Ignorance is not bliss, especially not in mental health. Insight can be poor. Doctors simply have to be attuned to the possibility of cognitive impairment due to any cause, especially in those older, more vulnerable populations. The take-home message is that patients rarely complain of cognitive dulling when clinicians specifically ask about side effects. I've never had a patient complain of slowed thinking, decision-making, short-term memory lapses, etc., in response to my asking about side effects. They're not going to say, oh yeah, I'm cognitively slowed. So that's what I hope this presentation today has maybe improved awareness a little bit, improved insight. Those of you out there who are taking medications that may be dulling your cognition, to think about it, to kind of make that connection like I did with Lyrica. But it's important because this loss can affect your occupational, academic, and even social performance and decrease the quality of your life otherwise. And it should be included, this detriment should be included in the risk-benefit analysis that is part of the ongoing process of obtaining informed consent for taking any medication. Last thing I'll say is that oncologists and their patients on chemotherapy for cancer treatment have heard about Chemo Brain, but chemotherapy refers not just to treatment for cancer. Patients may not know this, but chemotherapy means treatment with chemicals, with medication, as opposed to surgery or radiation or other forms of treatment. So all prescription medication therapy is chemotherapy. All medication therapy is chemotherapy, including over-the-counter. So Chemo Brain is something that can occur in patients who don't have cancer, who are taking Benadryl for insomnia. That's technically chemotherapy. We wouldn't miss brain fog due to cancer chemotherapy because it would have a sudden onset in an otherwise previously cognitively intact individual, and it would be significantly disruptive. But we might easily overlook brain fog in a middle-aged or perhaps semi-retired individual whose cognitive dulling is due to a highly anticholinergic over-the-counter medication. For example, when those symptoms are mild initially and insidious. It may take a certain dose before you reach that critical threshold. It's just never obvious to the patient that that's what's going on. The important idea here is that the deficits can be insidious. They might appear shortly after starting a medication or more gradually over time. They are often dose dependent, usually, I would say. So the starting dose of a medication might not tip the scales. But even when these deficits do begin immediately after starting a medication, if they're mild at that dose, the patient may not notice. So that's it for part 1. Please look for part 2, in which I will discuss the usual suspects, medications commonly implicated in this side effect of cognitive dulling, and the various mechanisms whereby these agents disrupt our ability to think and know. Thank you for watching, and as always, comments and questions are welcome.